Welcome everyone. Thank you so much for joining us today at this special webinar event in collaboration with Protocol for Life Balance and Fullscript / Emerson Ecologics. I'm Amy Regan from Fullscript, and I am so glad that you joined us today. A few housekeeping notes. Please place all questions you have in the Q&A box for a chance for them to be answered at the end of the presentation. This webinar is being recorded, and the recording will be sent via email to all attendees and registrants, and there is a copy of the presentation slides in the handout section. It is my pleasure to introduce Dr. Cindy M. Howard. Dr. Cindy M. Howard is a board-certified chiropractic internist and nutritionist in private practice and the owner of Innovative Health and Wellness Center in Oakland Park, Illinois, and holds a license in the state of Florida. She owns DC Consulting, assisting private practices improve their communication skills and improving patient adherence while building a better functional medicine and nutritional practice. For the last 12 years, she has served as the Illinois delegate for the American Chiropractor Association and as the alternate for 6 years prior to that. She was the ACA recipient of the Flynn Lynch Award in 2015 for outstanding service. She is a past president of the ACA Council on Diagnosis and Internal Disorders and currently serves as the vice president of the College of Pharmacology and Toxicology. She serves on the medical advisory board for Fullscript, the Functional Medicine University, and is the chief medical officer for Ingardia Health. Dr. Howard is the associate editor of the Original Internist and a regular contributor for the Illinois Chiropractic Society online newsletter. She speaks nationally, presenting topics including pre- and post-concussion nutrition, headaches, sexual health, male and female pelvic disorders, GI disorders, nutritional blood analysis interpretation, and genetics. In 2020, Dr. Cindy Howard was awarded the Chiropractor of the Year from the Illinois Chiropractic Society. Additionally, her first book, Positively Altered, is due out in September of 2023. That's coming up, Dr. Cindy.
It is pretty soon.
Excellent. We're so glad to have you, and we're so excited about this topic.
Oh, Amy, it's an absolute pleasure. I'm thrilled to be spending the next 45 minutes to an hour with all of you. We're going to talk about taking action when patients have pain. We ready to go?
Yes, we are.
All right. I'm glad you responded because everybody out there, I'm sure, is screaming and I just can't hear. So we're just going to make an assumption that I gotta, oh yeah, we're ready. And we're gonna plow right in. So I just really would like to reiterate a big, huge thank you to Fullscript and to Protocol for Life Balance, who sponsors me to speak around the country. And they're just a fantastic company to work with. So a big, huge thank you there. I know that Amy took some time to read to all of you a little bit about me. And if you didn't catch that all quickly, here's a lovely laundry list of a lot of that in print. However, I do want to point you to the top right-hand corner of this slide so that you have my contact information. If you look, Dr. Cindy Howard at msn.com is my personal email. And underneath that is my personal cell phone number, 708-646-6561. So at the end here, and I know we'll take some questions, I'm happy to stick around to do that. But if things come up or you think of something, later tomorrow, next month, and you want to reach out, please feel free to do so. The best way to get a hold of me, though, is via text. Shoot me a text, throw your name in the message, where you heard me, and I'd be really thrilled to get back to you. If you shoot me an email, quite honestly, I get buried in emails, and a lot of times they do just get ignored, not intentionally. So just know that you're going to have to stalk me by text to say, hey, Dr. Cindy, I sent you an email. Please check it out, and then I will get back to you as well. Also, if you're just interested in following me and seeing what's going on with the new book that Amy mentioned, you can text Dr. Cindy to 66866 or go to drcindyspeaks.com and subscribe to my newsletter. I hope you all will check out the new book. I'm really very proud of it. It's my memoir of my walk through Hodgkin's lymphoma, and it's really about building a tribe and overcoming adversity and having fun while doing it. So enough about how to get in touch with me or follow me. Let's dive into what we're going to talk about today. So basically, there's two main objectives that I want to hit for you. One is how to use supplementation for pain easily and safely. Now, that being said, in the amount of time that we have together, certainly know that this list is not the entire list of things that we can use to address pain. What I did is I put together a relatively small but good list of some of my favorite ingredients that have been very effective in my practice over 25 years for different types of pain. And that's what we're going to walk through today. I also want you to learn specifically about those key ingredients and how they work. We'll talk a little bit about dosage, and I'm going to share with you a few case studies that are real patients in my office and how I utilized those ingredients in order to eliminate some of the pain that they were experiencing. So those are our goals for the time that we have together. So first, I would love to introduce you to Mike. So Mike is our first case of the day, and he has been a patient of mine for a very long time. He's an accountant, so he's got a pretty great desk job, and certainly in season spends a whole lot more hours at his desk than off season, but it's a sitting position. And some of his history in terms of exercise is he was a very serious runner, and he participated for years in different marathons when he was in his 20s. Now he's 56 years old and has, as he describes, slowed down quite a bit. Some significant history. Mike has actually dealt with the diagnosis of Lyme disease that until he came into my office was dealing with an array of symptoms, mainly pain in a lot of his joints for years that went undiagnosed without the ability to find the underlying issue. After the diagnosis of Lyme disease was discovered, certainly that was addressed, and we moved through a lot of the components of pain, but there were still aspects that stuck. So now at 56 years old, he, occasionally runs because he really misses it. But based on his schedule, he's going to overdo. He's going to run like he did when he was training for marathons. And that's only a couple times a month. And then what's going to happen is it's going to take him 4 to 5 days to recover from that activity due to the fact that he goes all out, maybe inappropriately so, right, without proper training or a proper schedule. He also will enjoy bike riding. He'll do up to 40 miles on the weekend with his wife, but again, no consistency there. So some of the pain that he is experiencing is still a result of some of his exercise choices when he goes gung-ho versus sitting around and doing his work. So I want you to just keep Mike in the back of your mind. And as we near the end of the presentation, I'm going to share with you some of the things that we did together in order to help him. So pain is a pretty common complaint, and I don't think that's going to surprise any of you. There's not a day that goes by in the office, right, that when you ask a patient, what are the main reasons you came in to see us, pain is absolutely going to make that list for a lot of us throughout the day. The CDC actually reports that approximately 100 million Americans suffer from common chronic pain conditions. And you're going to see some stats in these next few slides that are going to be a little bit different, but just to show the significance of how common this is, I think those stats are very beneficial. What's interesting is they state that the amount of Americans that suffer from chronic pain is more than the number affected by cardiovascular disease, diabetes, and cancer combined. What's interesting is if you look at those things, those disease processes, there's also pain that's associated with each one of those. So there's lots of different underlying causes besides these three, but it's a very significant concern for all of our Americans. The prevalence of chronic pain has been measured anywhere from 11 to 40%, which is pretty broad. And it probably depends on the research that's being done or any given day. What's really interesting is when we start to think about those numbers, we have to be concerned with the fact that out of these millions of Americans that have pain, a lot of it actually interferes with our daily life and our work activities. And as we know, that's going to be one of the common goals, right, is for patients who come in with pain to be able to get back to work or work more efficiently, to be able to spend good quality family time or even alone time doing the activities that they really enjoy without focusing on the pain that they're experiencing. Back in the 1990s, we had a pretty drastic turn of events, and we were looking at ways to improve pain control. And what morphed out of that desire to help was basically the liberal prescription opioid problem, right? So it became really easy to walk into a doc's office, get a prescription medication to help lower that pain threshold, theoretically solving a problem, which we all know isn't really true. And now we've got an actual crisis on our hands. It was interesting. Just the other day, I was, trolling on Facebook, going through my feed. And in one of my mom's groups, there was a woman who posted, does anybody know of a doctor who I could get in quickly to see, to just walk into the office to basically get a prescription for pain because I'm in so much pain, I don't know what else to do. And of course, my first train of thought was to respond, although I don't necessarily do that in public forums. I like to private message if I do that, but was to respond, how about looking into why you have the pain in the first place and coming up with some really good tools in order to mitigate that before running to get a prescription that could potentially be dangerous and certainly life-altering, right? Especially due to the fact that we can become addicted to some of these things. So we know the crisis is real. We're still battling it. I'm here in Chicago. It's a big problem here. There's overdoses all the time due to some of these medications. And unfortunately, when you read about that in the local news, it becomes a very sad state when we know that there are many ways that we can help. So just some more fun stats just to show, the intensity of the problem. Over 932,000 deaths, and I'm sure that number just keeps climbing and climbing since 1999 due to a drug overdose. Back in 2020, so just a few years ago, there was an average of 44 people who died a day involving prescription opioids. And certainly, I'm going to go on a limb here and say all of those could probably have been preventable. 10.3 million people aged 12 and up misused opioids. Let me do that again. 10.3 million people aged 12 and up misused opioids. When I see something like that, and I think about all of our young teenagers that are being prescribed these drugs as well, the level of sadness, of course, just increases due to the fact that we're putting them at greater risk. 9.9 million people misuse prescription pain relievers, and 1 in 3 Medicare Part D beneficiaries received a prescription opioid just in the year of 2016 alone. And we know the numbers are climbing. There was a study done at NORC at the University of Chicago. NORC is the National Opinion Resource Center here where I'm located. And it was interesting. They took a look over a 2-year period and showed that 18% of adults received an opioid prescription last year. 91% of those people that were prescribed it filled it, and 29% refilled it at least once. The most common physician to prescribe these are surgeons. Second, then our primary care doctors. And then 23% actually came from dentists or oral surgeons. So, maybe some education in that space too, in order to start to elicit some changes. So as I think all of you out there that are listening know, we have some better choices. More than 1/3 of Americans now are using complementary and alternative medicine. That word alternative really should be first line, right? So we'd love for everybody to come in and pick some of these choices first. Certainly there's a time and a place for prescription medications on some levels. In my opinion, never as a primary recommendation, as I think we do have some great alternatives. So let's talk just real briefly about the different types of pain that we can experience. And I want to comment a little bit on all of those. So first, which we mentioned in the stats, is just chronic pain. And chronic pain, of course, is defined by pain that lasts many months or years. Some typical types of pain are going to be arthritic, certainly migraines, fibromyalgia. And there's not a week that goes by that we don't see all of these conditions in the office. In the National Health Interview Survey back in 2019, roughly 1 in 5 adults had chronic pain in the US alone. That's not even worldwide. And more than 7% again had chronic pain that limited their activities at work or in life. And one of the things that we look at when we deal with chronic pain is really tracing back where it started, right? So we have to take a look and say, okay, what led up to that onset of the chronic pain so that we can try to decipher what the underlying cause is, and while we're treating the pain, be able to help eliminate that. Nociceptive pain is caused by any sort of tissue damage, can be a result of cuts, burns, fractures, or bruises, or any other condition that causes tissue inflammation and damage. And again, arthritis is going to fall into that category. Certainly osteoporosis, irritable bowel disease. I find osteoporosis pretty interesting. When I first started practice 25 years ago, we were shoving calcium down patients as fast as we possibly could, because the literature at that time said, let's just supplement with 1,000 to 1,500 milligrams of calcium, and we're going to prevent osteoporosis because it's all about calcium. And that was also the time, those of you that are old enough probably remember that milk campaign. Remember all the stars? They'd be in the magazines and they'd have the milk mustache and it would say, "Got milk." And that was the big, recommendation. We've got to drink our milk to prevent our osteoporosis. And I look back at all of the people in that generation that drank milk that still had the osteoporosis. And we now know and realize that we got that wrong. And it's not just about shoving calcium down, right? It's about taking that calcium in the serum and getting it into the bones. And in order to do that, we need a lot of the great cofactors. We need vitamin D, molybdenum, boron, manganese, vitamin K, etc. And there are so many different aspects now to look at in order to increase that level of nutrients in the bone to help prevent osteopenia leading to osteoporosis. That, things like this in the pain world, we're starting to learn so much more, where now we've got some better tools in order to offset some of these issues that people have been living with chronically. On a somatic level, this is anything that happens in the skin, the muscles, tendons, bones, joints, or ligaments. And if it's visceral pain, this would be anything internal. And nociceptive pain can certainly be acute and lead its way into a chronic state. We've got neuropathic pain. This is nerve damage such as herniated discs, shingles, diabetes, MS, and cancer. 10% of our adult population will experience neuropathic pain at some point during their life. And it gets described as something stabbing, shooting, prickling, or burning. This can also include hypersensitivity to touch, movement, or temperature changes. We've got a really great case right now in the office. A woman in her late 40s who walked through shingles that 6 years later is still having some degree of neuropathic pain from her eye, right side of the forehead, leading to the top of the head, that is continually getting better, but still present. So certainly in a chronic nature. I want to introduce you then to our second case study, which is actually going to be Mary. Mary is a personal trainer, and she also has been a long-term patient. What's interesting is while Mary is in excellent shape, weight is absolutely ideal, doesn't carry any extra fat or weight in general on her body, eats super clean, outstanding diet, knows how to hydrate, keeps her hydration well. Water is the only fluid that she consumes. Due to the nature of her job, there's some interesting components of it that absolutely inhibit her function. So her history involves a herniated disc at L4, L5. And as a result of her teaching and training, she is constantly on different surfaces, different floor surfaces. She loves to wear different brands of shoes, so she's constantly changing the source that is underneath her feet. She bends an enormous amount, even though she's conscious of that enormous amount at the waist in order to help and assist some of her clients. So that herniated disc tends to rear its ugly head every once in a while, causing a lot of radicular symptoms down both legs and certainly localized low back pain. So keep Mary in mind as we keep going. And lastly, we have the functional type of pain. Now, functional pain is usually a cause of chronic pain that is not considered identified, and there is no underlying injury or illness. 15% of the people in the world fall into this category as having functional pain syndrome. And the types of pain that are common here, fibromyalgia, again, irritable bowel syndrome, TMJ, chronic cardiac chest pain. Now, this comes straight out of the literature, but I do want to, again, challenge all of you to start to think a little bit differently. A lot of times we're just not looking far enough down the rabbit hole to understand that a lot of times there is something underlying some of these cases. So for example, in irritable bowel syndrome, we know that with an irritation that causes either a constipation or a diarrhea multiple times over multiple months, stress can be one of the mitigating factors. Certainly, we know there are certain foods that can cause inflammation in the gut. We look at the entire microbiome now of the gut to see if there are other underlying factors, viruses, yeasts, fungus, parasites, bacteria that could be contributing to an irritable bowel syndrome, eventually leading us to irritable bowel disease. And this is just one small example of how functional pain sometimes gets overlooked and ignored in a way of treatment because we don't dive deeper to find those underlying causes. So, as mentioned, because of the opioid crisis, we all know that there are some answers that we can have at our fingertips in practice every single day. And what we're going to now dive into is some of the non-opioid answers to help address some of the pain that patients are walking through while we do the good work, regardless of the background. Whether you're a chiropractor, a nutritionist, a naturopathic doctor, a medical doctor, and for everybody else that I've missed, we all have our tools that are very valuable. And while we walk through utilizing those, I want to make sure that we have some options to give to patients for pain relief. So my very first one that I absolutely love is white willow bark. This one has been around for over 4,000 years. It was used in history by Sumerians, Babylonians, and even our ancient Greeks. And what's great is we now have literature that's been publicized and produced not only in America, but in Europe and actually the entire world. So it's documented in a lot of ways so that we can have valuable research to support the recommendation. What we do for white willow bark is it's harvested usually in the early spring. It comes from 2 to 3 year old branches off of the tree, and it's utilized by activating the bioactive constituent. The main constituent is salicin, which is metabolized in the body into salicylic acid. So when you think about white willow bark, this is very similar to aspirin in a way that this is the active ingredient that is used when you're taking over-the-counter aspirin. So in white willow bark, we use it a little bit more in an unprocessed natural state. This also contains polyphenols, including flavonoids and proanthocyanidins, which are very anti-inflammatory. These factors help regulate the normal balance of key immune mediators by inhibiting cyclooxygenase 2 enzymatic activity, leading to an analgesic effect that we're trying to accomplish when a patient has pain. And what's fantastic about the white willow bark as a natural substance is when taken orally, we can get to peak levels in less than 2 hours. So it still can be a very quick fix for patients, just as they would pop any other over-the-counter, and hopefully this could be a good replacement for them. Typical dosage is going to range a bit, anywhere from 400 to 1,600 milligrams taken every day in divided doses. This can be used, every 2, 3, 4 hours as you see fit based on the actual pain response. If it goes down, we can spread those dosages out a little bit more. If it seems to persist, we can up that frequency until we hit the right dose at the right frequency. Second thing that I absolutely love to use, and actually even in conjunction with the white willow bark, is ginger. Ginger was really known initially when I first started studying a lot of the nutrients, is something that we used more for GI and actually for nausea. So it was a great remedy. Eating it raw, especially, awesome for nausea. But for centuries, it's also been used directly for pain relief. This also contains active constituents and bioactive compounds, including volatile oils. And the pain relief is due to the inhibitory event of 6-Shogal on the release of substance P. And substance P is associated with the normal immune response when the body is under stress and for pain perception. It regulates the normal balance of key immune mediators released when the immune system gets triggered. So especially if you couple now pain response, not just on the musculoskeletal side, but on a lot of the gastrointestinal side, this is really a very effective product because we know that we carry a lot of our immune system in the gut. And when the gut isn't functioning well, then we have trouble responding to some of the pain. So if we can support immune function in the gut, that's going to improve. Another great thing about ginger is it's actually used for its antibacterial properties as well. There was a fun study that was done showing 4 grams of ginger powder for 4 days prior to high intensity resistance exercise has been shown to show support muscle recovery. So think back to Mike, how he's doing some of his weekend warrior bike riding or his running, and he is taking 4 to 5 days to recover. Sometimes we can be even proactive in that cycle of pain. So certainly easy to give ginger when somebody has pain, but when we know they're going to do something that is going to elicit a pain response in which we need to stimulate recovery, ginger might be a really effective tool to use. It's also really awesome for overexertion and any pain related to the women's menstrual cycle. So if there's nausea with PMS or during menstruation, if there's menstrual cramps, any sort of pain over the ovaries, even pain, again, due to GI that sometimes relate with the menstrual cycle, ginger can be very beneficial for a lot of our female patients. Additional benefits: relieves digestive pain and stimulates digestion. So it also helps with that process so that we can break down, digest, and absorb our food better. As I mentioned, it's anti-inflammatory. This also stimulates blood flow. It lowers platelet aggregation, and just to reinforce, kills bacteria. So any bacteria that could be harboring in the gut or actually in the bloodstream, ginger is a wonderful product. You can start with about 1,000 milligrams every day of ginger, maybe work up a little bit, but 1,000 is pretty darn good. Boswellia, my third favorite on in that combination. So these 3 I tend to use together. It's awesome for awesome for minor aches and pains, excuse me. And the main bioactive constituents is boswellic acids. So you want to make sure that you're finding boswellic acids that are standardized to what is known as 3-O-acetyl-11 keto beta boswellic acid. And for those of you that can't say that 10 times fast, we're going to just abbreviate it as ACBA. Okay, so that's what you're looking for in your ingredient of Boswellia. This also helps to regulate the balance of immune mediators released when triggering the immune system. Great for overexertion. Also helps to preserve and maintain healthy joint tissue through its effects on MMP3. MMP3 is one of those inflammatory markers that is very commonly looked at in a lot of our stool testing. So there's many markers that we can see elevation of, and if that MMP3 comes back positive on a stool test, Boswellia is hands down probably my first go-to to help reduce that inflammatory response. It's really important to know when using Boswellia that if it's not bioavailable, it's not going to be as effective. So look for that ACBA on your products and make sure you're getting into your patient's hand the most bioavailable form possible. It's also a potent anti-inflammatory. It improves blood flow to damaged cartilage. It inhibits something called 5-LOX, which is very similar to COX, but the 5-LOX is actually what drives our osteoarthritis. So in patients that are starting down that pathway, Boswellia would be a great adjunct to their daily routine. It's also been known to help Crohn's disease, and again, that's due to the anti-inflammatory processes in the gut. Any pain associated with the cancer diagnosis, lupus, and certainly our headache patients. 500 to 1,500 milligrams every single day. Divided doses, again, would be best. And take this with a fat-containing meal. Sometimes that actually helps to increase the absorption of the product when you have it with a fat. Apres Flex, just want to throw this out there. This is a proprietary extract that has been clinically shown to reduce minor aches and pains from overexertion within 5 days of supplementation, and also increases joint mobility and helps with occasional pain up to 90 days. So this is a proprietary blend that, again, you can look for on your products. 50 milligrams twice a day was used in this particular study to show these particular results. There's also a really cool study that took a look at 5 different herbs. They took the Boswellia and they combined that with stinging nettles, horsetail, ginger, and celery. And it showed that these in combination were fantastic for anti-inflammatory pathways as well as analgesic properties. There was a significant reduction in perceived pain and improvement in functional mobility that had occurred for an intervention group as related to their chronic joint, back, and muscle pain. They also, in this study, coupled it, interestingly enough, with vitamin B1, which is also known as thiamine. And all of these were extremely well tolerated as a blend, which was actually pretty cool in all of these chronic musculoskeletal pain patients. So sometimes it's really fun to use these as single entities, but it's also pretty powerful to couple them and use them as a combination product. Sometimes we see a lot more effectiveness that way, and sometimes even much faster results. Dosages, here you have the dosages that I like to use on the 3 that I do together. So the white willow bark, the ginger root, and that frankincense is the Boswellia. Okay, so you can play with those dosages either by themselves, as I gave you, or find a lovely combination product where they're all together that looks somewhat similar to this one. Case number 3 I want to share with you is Katie. Katie presented to my office with chronic headaches and PMS. That PMS, or that premenstrual syndrome, actually included the headaches as well. Now, here's a little side note for all of you. When you have a patient that presents with any symptoms surrounding their period, I want you to become familiar with using the words common and not normal. Myself included, when I was younger, we were all taught that, headaches, mood swings, cramping, crying for no reason. Oh, that's just what we go through as women. It's totally normal. Go to bed, lay in the fetal position, take your painkillers. My mother was a big fan of blackberry brandy as a remedy back in the day for some of the PMS cramps. And that was it. And we just kind of suffered, if you will, through every single month. Well, I want to share with you that all of that is common, but not normal. The only reason a woman should know that she's got her period is it's day 28. She goes to the bathroom, she wipes, there's a little bit of blood, and she goes, oh, it must be day 28, and I'm here with my period. Any other symptoms are completely abnormal and can absolutely be corrected by looking at nutrient status, hormone balance, stress levels, etc. In the meantime, Katie comes in, and she is suffering from some of those things, but the main concern is really her headaches. They're weekly. All right. And Katie actually has a good diet as well. We talked about some of the things that could stimulate headaches, artificial flavors, some of the additives and chemicals, inflammatory foods, sometimes like dairy and gluten can be triggers, chocolate, caffeine, and none of that was a concern for her. She was eating absolutely very clean. So diet was excellent. She also was getting adjusted regularly. So when we look at headaches from a musculoskeletal component, sometimes we assume that by balancing the musculoskeletal issues, the headaches can go away. But in her case, it wasn't making an ounce of difference to get good adjustments in musculoskeletal care. On the nutrient side, it's really interesting. We find a lot of deficiencies related to pain or things that can help. Zinc is a very interesting mineral that I think is commonly overlooked. And there was a cool little study of 100 patients with severe head trauma aged 18 to 65. And they administered zinc in the dosage of 120 milligrams, which is actually pretty hefty compared to a placebo. And it had a very profound effect on some of the inflammatory markers. 2 main ones that we test in laboratory work are ESR, or SED rate, and C-reactive protein. And this is a big one that we see actually in a lot of our concussed patients that have headaches and other pain associated with the concussion. We see a deficiency in zinc. And we look at this both in a serum value and a red blood cell value. So for those of you ordering labs, please also make sure you get a red blood cell value on the zinc so that we can make sure within that red blood cell we're getting adequate levels. So don't overlook the value of zinc on your patients. Do be careful, however, when you're prescribing it, as there are many forms of zinc. Some of them can be pretty harsh on the tummy. So if you have a patient that doesn't do well, make sure they're taking their zinc with their food, or you can change up the form of zinc a little bit to find the one that works nicely for them. 2 of my favorites are going to be zinc glycinate and zinc carnosine that I typically use. And most of the time, those do not cause any sort of GI disturbance when taken correctly. Then there's those B vitamins. We briefly mentioned B1 or thiamine, but B vitamins really are an important cofactor for our neurotransmitter production. They also help us rebuild and strengthen muscles, and we have a tendency to burn through them pretty quickly. What also commonly gets overlooked is this is one of those sets of nutrients that are also usually deficient as a result of nutrient depletion as a result of prescription medications. Antidepressants are a big category for that. Birth control, certainly. We find a lot of these patients are getting deficient as a result of some of the meds that they're being put on. And it's just essential that even if those are really a necessary evil, we've got to start measuring all the levels of the B vitamins to see what we're burning through and what we actually need to replenish. Vitamin C, another big one. There was a great study where patients with rheumatoid arthritis were looked at, and they were found to have less than half the level of appropriate vitamin C compared to certain healthy patients. And vitamin C, we get it through foods. Foods, certainly, citrus is a really great one. Dark green leafies to a certain degree. Excuse me. It's important because it removes lactic acid. It's also a huge cofactor to build collagen and repair muscle, and it's awesome post-workout. Vitamin C, however, though, is very hard to dose, and we typically recommend doing that based on bowel tolerance. So what that means is we prescribe a certain amount, whether you're doing a capsule, tablet, powder. We start anywhere in the neighborhood of 500 to 1,000 milligrams of vitamin C. And every day or every couple days, depending on how sensitive we think our patients are, we increase that level of vitamin C until they experience some diarrhea or loose stools. The philosophy behind that is what you're not utilizing in the body, you then have to excrete, which is causing the loose stools. So once we get to that bowel tolerance, we back off about 75–80% of that dose that got us to the loose stools, and that becomes our maintenance dose as long as the stools are formed and back to normal. Now, I know the question is going to come up, well, what do we do with the patients who already have diarrhea? And that really is going to warrant running down that rabbit hole if we've got to figure out why the diarrhea then in the first place. Fix the diarrhea so we can overcome that obstacle, and then dose the vitamin C appropriately so that we can get patients on what their bodies can handle. Vitamin D, this is a big one for me. Vitamin D deficiency is just rampant, in my opinion, almost no matter where you live. I'm licensed here in Illinois, but also in Florida. So I do a lot of telehealth in Florida, and patients will present with a lot of their labs, their vitamin D sunshine state, right? And yet we are seeing low levels of vitamin D even chronically in our sunshine state. So really important that we're checking that. Relationship to type 1 diabetes, hypertension, metabolic syndrome, heart disease, certainly anything related to falls, broken bones, depression, and even cancer, we're seeing relationships. A lot of times when we run the labs, the clinical value will sit somewhere between 30 and 100. I like my patients to sit at a level between about 60 and 80 as kind of my magic marker. 30, I would still consider nutritionally deficient. Watch some of those heavy doses one time a week. They're not always the active form of vitamin D. I do like using D3 in its active form daily. You can do that in capsules. Certainly sublingual is also really nice, especially for those that are having trouble absorbing and digesting fats, because vitamin D is a fat-soluble vitamin, and we need to make sure that the gut is working that way. So sometimes the liquids work even better. Vitamin D deficiency has been linked to all kinds of joint pain and headaches. And a lot of times those patients that are taking the high doses of opioids, a lot of times we see the deficiency here as well. So make sure that you're looking at vitamin D as one of your first line vitamins to help lower the inflammatory response and help with bone regulation and hormone balance. Barrage oil, another one that I think is really important. This one I think also commonly gets overlooked. So when we talk about different omegas or fatty acids, GLA as an omega-6 fatty acid has a hormone-like anti-inflammatory activity and can actually help repair damaged nerve fibers. When you're giving patients fish oils and they're taking their EPA and their DHA, please make sure if you're using that for any sort of chronic condition, you couple that with the GLA. That is what helps continue that anti-inflammatory pathway so that it stays consistent for a long period of time. There was also a small study that was published in the International Journal of Immunopathology and Pharmacology back in 2009, and they showed that just 420 milligrams of GLA showed a significant reduction in symptoms in 203 patients with spinal pain. So good for your RA patients, your osteoarthritis patients, anyone with PMS, and even eczema. There's some great studies to show that it helps to reduce those skin changes, and certainly there's pain that goes along with a lot of our skin conditions as well. Magnesium, this is probably my favorite mineral, hands down. And one of the reasons is we commonly see deficiencies in patients all the time. So big one is migraines. All right, lots of studies to show that deficiencies in magnesium play a role. We also see a lot of imbalance in magnesium levels in our patients experiencing fibromyalgia. This is another one that reduces levels of substance P, which will help correlate to the decrease in the pain that we feel when we're labeled in that fibromyalgic state. This is also good for headaches related to menstruation. Do be careful because magnesium helps to lower blood pressure. So for those patients experiencing high blood pressure, or if they're on blood pressure medications, this can be used, but make sure you're monitoring that, because we certainly don't want to send them in the opposite direction where we go from high to low, and now, we've got them passing out due to low blood pressure. So make sure you're monitoring that close. When you run magnesium levels in your blood, if you choose to do that, please order a red blood cell magnesium there as well. Serum magnesium is what's commonly ordered. It's very difficult to measure adequate and accurate levels of magnesium in blood to begin with, so that red blood cell magnesium tends to show a more accurate representation. If you're going to use forms of magnesium, there are many. My favorite from a pain standpoint would be 3 and 8. 3 and 8 crosses the blood-brain barrier, really good for anything brain-related. Glycinate and oxalate, also really good for headaches and muscle aches and pains. Do be careful with magnesium citrate, as that one, if you tend to dose that pretty high, can also lead you to a diarrhea. So 600 milligrams, you can play with this. Sometimes it's a lot less that works. Sometimes we'll go as high as even 1,200 or 1,400 milligrams. But 600 would be a really good starting dose to play around with your patients, especially if you're not getting a magnesium level. If you do test red blood cell magnesium, my magic number is 6. So if you have a patient that's, let's say, 5.2, still having some of these symptoms, you're going to definitely dose lower. Sometimes I see magnesium as low as 2 or 3. Then I'm absolutely going to pick a higher dose at that point in order to get them there to a proper level much faster. The College of Family Physicians of Canada had an interesting report showing that magnesium deficiency is more common than believed. And you can see on the right there, these are the most common symptoms associated with magnesium deficiency. So muscle aches and pains, cramping, sleep issues, especially insomnia, anxiety, headaches, and elevated blood pressure. So any patients that are experiencing any of these symptoms, whether it's associated with pain or not, magnesium would be a great choice. Post-workout, especially if it's oh, doc, I'm cramping all the time after I work out, or I'm getting significant muscle aches and pains, even including that delayed onset muscle soreness. Magnesium on an empty stomach so that the food doesn't interfere with the absorption might work absolutely nicely. And even you can see in these studies, they work up to even 2,000 milligrams of the magnesium. Turmeric and curcumin. This is compared to tramadol for neuropathic pain, being effective with less degeneration and high levels of regeneration in the nerve tissue. There's also been some great studies showing how effective it is versus NSAIDs for knee osteoarthritis. So one of the great go-tos. Do be careful just a little bit with this particular substance, only because we have seen some patients who are sensitive or allergic to the spice. This, along with your omegas, is also a blood thinner. Oh, and by the way, vitamin D can be a blood thinner too. So make sure if patients are on blood thinner medications, that we address this. And actually, I know we've got a bunch of questions. I'm going to get to some of them at the end, but I just caught out of the corner of my eye the one about thinning for surgeries. The question was pertaining to white willow bark, and the answer to that is yes. So if your patients are going to be experiencing any sort of surgery, It's really important that anything that could thin the blood is removed for a period of time. Most surgeons will recommend at least a week out, probably smart to be safe that way. Curcumin is going to fall in that category, white willow bark, potentially even the ginger, certainly vitamin D, absolutely vitamin C, and your omegas. And then you can pick that back up once the surgeon, post-surgery gives them a check mark on the procedure to start those supplements again, assuming everything went perfectly. Laboratory work. I'm a huge fan of laboratory work. So for those of you that do that or have access to that or can even ask your patients to bring in their lab work, some key inflammation markers and deficiencies that I look for. One is that red blood cell magnesium for sure. We always run a CBC, a comprehensive metabolic panel. We look at the level of white blood cells and the components, the different blood cells. So neutrophils, lymphocytes, monocytes, basophils, and eosinophils. We look there to see if any of those levels are off that could indicate any sort of infectious process. We also look at the red blood cell count to look to see if there's any levels of dehydration and to see if there's any underlying anemias, which would indicate either an iron deficiency or a B vitamin deficiency most commonly. A comprehensive metabolic panel is going to have us take a look at our glucose levels, certainly our liver enzymes and our kidney enzymes, looking to see if there's any reaction in those two organs that would cause us any sort of concern. We're going to look at LDH occasionally, which measures cell reactivity. And if that's elevated, that is an indication of inflammation. Same thing with ferritin. Ferritin is commonly associated with iron. So when we get too much iron and we store it abnormally, that increases the ferritin level. It can also be an indication for what's known as hemochromatosis. That's the abnormal storage of iron. But when we see the hemoglobin in the CBC, we see the iron level normal and that ferritin is skyrocketed. That's what we call an acute phase reactant, which then is considered an inflammatory response. And it's definitely a red flag. B vitamins, D vitamins, again, looking to see for any deficiencies so that we can appropriately supplement. And then interestingly enough, homocysteine is a marker that's used sometimes in cardiovascular health. And when that level is over 12, we start to think about cardiac inflammation. When it's over 7, we start to think about the speed in which we neurodegenerate or that our brain cells die. And homocysteine is a marker that relates us back to the methylation process of our B vitamins, mainly B12, B6, and folate. So when that homocysteine is elevated, we start to look back to see if we need to supplement on the B vitamin level, because those will drive the inflammatory response of the elevated homocysteine down. So some really good markers and blood work that we can use to help guide us with some of these nutrients that we're actually using. Fourth case I want to share with you is Everett. He's a wrestler. He is in season from October to March, and in the off season, he still trains. So it's really a year-round activity. In season, he's going to have up to 2 meets a week and weekend tournaments. So pretty active. And while it doesn't sound like a lot to go 2 minutes each by 3 periods, if you've ever watched or experienced a wrestling match, they lay it all out. It is 100% physical, mental, and heart on that mat. It's pretty tough. And Everett had a pretty significant history of shoulder injuries, torn labrums, pretty common in this world of wrestling, 1 previous surgery, 1 shoulder that he's rehabbing and babying, and he wrestles in college. So he is our 4th case of pain that we have today. So with our few minutes left, I just want to roll through real quickly these cases in the backward order to show you some of the things that I did utilizing these basic nutrients that I covered today. So for Everett, while he's in school, some of the things we certainly have to be careful of is he's, subject to NCAA rules, of course. So there's certain nutrients that we have to be careful with. We did use a combination of the white willow bark, Boswellia, and ginger so that when he had pain through the tournaments, even pre-tournament, anticipating the pain, we would load him up a little bit, utilizing that along with the collagen, the vitamin C, and the D for repair. Amino acids, we do a ton of amino acid testing, making sure that because they diet down pretty significantly, that with the protein that they're choosing to eat, they're getting adequate levels of their amino acids. And sometimes we find some pretty significant imbalances. So we did supplement with an amino acid formula for him. Magnesium a lot of times to help with that muscle recovery. So magnesium prior to the meets as well as during recovery. And certainly supporting him through physical therapy. At college, he's now getting it from his trainers there, adequate bracing, staying in physical therapy modalities, and utilizing in-college laser therapy. And when he returns back home, we use Takar therapy, which is capacitative and resistive electrotherapy that actually helps to reduce inflammation, restore some of the tissues by opening up the cells to bring the nutrients in and allowing some of the toxic elements to come out. So those were the things that we used for Everett. And he's an ongoing case. So he stays on some of these pain mediators long-term because of the type of activity that he's going to engage in for the next few years. Katie was really a different story. Even though the pain was very chronic, it was very interesting because when we found some of the deficiencies that she was experiencing, all we had to do was replenish those. So on a micronutrient test, we found deficiencies in her red blood cell magnesium. Her vitamin D level was at about 17. B vitamins very, very low in her B12. And actually, interestingly enough, her B2, which is riboflavin, lots of research to back the correlation between low riboflavin and our migraine headache patients. So we replenished her riboflavin. We used about 200 milligrams of riboflavin, put her on about 8,000 IUs of vitamin D, 600 milligrams of magnesium. We used a combination of the glycinate and the 3-and-8. Also found a deficiency in inositol, which was interesting based on the fact that she also had some PMS issues. Inositol really helps regulate hormones. So we used about 1,000 milligrams of inositol, and then those omega-3s with the Barrage Oil. We actually did about 1,000 milligrams of the Barrage Oil along with EPA and DPA. One little side note just to watch out for in our female patients that have headaches that seem to be cyclical, sometimes it's not just the nutrient deficiencies, but it can be a drastic drop in estrogen that precedes a drastic rise in estrogen that also can be causing the headache. Some of these nutrients will help regulate that, but if it didn't, then we have to start to dive into some of the hormone work. She was real easy though. Hers was more about fixing the supplementation than giving her ongoing pain management. The second case study, we had Mary. She gets regular treatment. She comes in to get adjusted. We also utilize flexion and distraction to help with that herniated disc. We also utilize cold laser over that L4, L5 area to reduce the inflammation when that disc tends to act up. She was a perfect candidate for the combination of the white willow bark, the ginger, and the boswellia that we used for pain while we were treating her. Put her on regular doses of B12 and B6. The B6 we use in the form a lot of as P5P, pyridoxal 5-phosphate. 50 milligrams 3 times a day is a pretty good dose for radicular pain. And the B12, that one's hard to play with, but usually in the neighborhood of about 5,000 or 6,000 mcgs on the B12 works really nicely in combo with the B6. And then sometimes to throw a B complex at that helps because all the Bs tend to aid in absorption together. And then when she was significantly flared, we would throw additional curcumin at her, 500 milligrams 3 to 4 times a day to help increase that reduction of the inflammatory response. And Mary is just one of these patients that comes in for regular maintenance care. It seems like, once a year, maybe twice a year, she gets significantly flared. And that's how we use the supplements until she feels really good. We continue her on the B vitamins, and then she uses all of those herbal products as needed if the pain kicks in when we pick up treatment then at that time. And then there's Mike. So Mike, we use the combination again of ginger, boswellia, and white willow bark. We use that the day that he would do the cycling and then for the 5 days following while he felt that that was his time frame that he needed for recovery. Hydration in this case was also equally important. We wanted to make sure he was getting adequate water because what he was drinking during the course of his normal day, he was losing during that excessive activity through perspiration. So we needed to make sure that we kept that water intake up, loading a little bit before activity, certainly sipping on water during, and then rehydrating within 90 minutes of following that heavy activity. We also played around, which worked really nicely, with some higher doses of that magnesium prior and after to prevent some of that delayed onset muscle soreness. And same thing with the vitamin C, which we did to bowel tolerance, which worked really, really well. So you've got a nice little array of products that you can start using in your practice. One last thing I just want to throw out to you is not only what to use, but things to watch really closely for as to what not to use. And here's a nice little list for you that you guys can just screenshot or take a quick picture of. This is one of the things that I love about the Fullscript platform, which we use in practice all the time for our patients, not only locally, but especially for our patients out of town. And that is, we know that we're getting access to some really phenomenal companies and some really phenomenal products that are devoid of a lot of these different things that occur out there in the world that patients have access to. So make sure you're getting educated, and we educate our patients. Give them this laundry list so that they know what to look out for, that when they see it on a bottle, not to pick up and get, and certainly not to order, which on the Fullscript platform is very helpful because you will not find those things. Anyway, I want to let you know I rolled through a lot of this super quickly. Just to reiterate, my phone number, if you want to shoot me a text for anything I can help with, is 708-646-6561. A huge giant thank you to Fullscript for having me today, to Protocol for Life Balance, who sponsors me, and really to all of you that are taking a few extra minutes out of your day in order to educate yourself to help our patients truly get well. So Amy, I think that's it for me, other than diving into some of the questions that I missed. And I know, we had a tight hour, but I will hang tight for those of you that want to stay so that I can get those questions answered.
That sounds wonderful. I appreciate everybody's time here. It was such a wonderful presentation, information packed. So we really appreciate that, Dr. Cindy. So we see the questions sort of rolling in here, and we have a bunch of them. What we'll do is try to answer as many as we can, and we will have them answered after, and I'll coordinate to send them out to the question askers. So we have some questions about white willow bark.
Yep. And I see here, I'm going to just read it. If someone is already on regular aspirin per their allopathic physician, would white willow bark increase bleeding or ulcer risk? So from a bleeding standpoint, yes, because it is a blood thinner. I'm going to go ahead and say it shouldn't increase the risk on the ulcer, but I wouldn't necessarily dose both of those together, right? So I would refer them back to their primary care physician that prescribed it to recommend taking them off of it, right, the right way. And we can use white willow bark certainly in its place. One of the comments I'll make, and this is sort of a generic comment about a lot of things, is when you look at the pharmaceuticals that are out there, a lot of the reason there's increased risk with the pharmaceuticals is because they're actually formed from a plant source, taking the active ingredient that has the effect that they want, but eliminating all the inactive ingredients that wind up being protective for those particular products. And that's why a lot of times the alternatives, in my opinion, are much safer. Not 100% without any risks, but certainly much safer. And then I think does white willow bark have similar side effects to aspirin ringing in the ears? No, again, it shouldn't. However, let me give you this disclaimer on this, which is going to couple into some of the others too. It is very possible for patients to have allergies or sensitivities to some of these products. So sometimes the ringing in the ears as a side effect is really more about a sensitivity or an allergy to the product. Not always, but sometimes. So if they do tend to have that, then we definitely want to find an alternative, because it's probably more about that than it is about just the product itself. What about neuropathic pain, peripheral neuropathy? There was an alpha lipoic acid ? Yes, yes. And I didn't have enough time, as I mentioned, to cover more than the few products that I covered. So big fat giant, yes. 200 milligrams on that, all the way up to maybe 1,000, especially in our diabetic patients too. Huge for regulating blood sugar and metabolic syndrome. So yes, yes, yes to the alpha lipoic acid. And thank you, Doc, for asking that question. And then I see one more, I think, Amy, and you can let me know if we should keep going. But the question, and I'm not sure how to answer this, because she said, would you address tinnitus? But that was kind of it. So I'm not sure, was it the tinnitus as a result of taking some of these products, or was it treatment of tinnitus? So can I just send that back, Amy, to get a more clarifying question? And then offline, we can get the doc the answer that they were looking for.
Yep, definitely. Let's do that. How about we answer 2 more questions?
Okay, I'm ready.
Excellent, excellent. Let's see here.
Oh, there were more, weren't there? I
Yes.
missed all the. Oh
Yep.
my goodness.
If you
Okay.
scroll, you can see them. I just want to make sure we're choosing the best one to answer, of course.
Okay. So we did the alpha lipoic, right? Oh, let's do this one because I think I mentioned it, but just to make sure. How long after surgery should we hold herbs with blood thinning actions / knee replacement? So I'm going to give you the politically correct answer. I've always defer back to, right, the surgeon who gives them the check mark, right, that when they get released, because that way we cross all our T's and dot our I's. I'm going to tell you that if there's absolutely no risk or issue of, bleeding post-surgery, I have my patients start pretty much 24, 48 hours following that, because again, we want to help with the pain aspects. But again, if you are just not 100% sure you can dive into that, error on the side of waiting, always better, right? Just to make sure. What are your thoughts on hyperbaric for headaches and migraines? Another big fat yes. We actually have a hyperbaric chamber in our office. Love it. Getting 100% oxygen with an oxygenator is actually also going to increase the effects of that. We've seen some truly amazing results. So yes, go down that rabbit hole and start utilizing the hyperbaric oxygen, which is great. Let's see what else. Can you please comment on the MTHFR genetic defect and effectiveness of B supplementation need for methylated forms? Yes. So, okay. So the MTHFR is a gene that, pick a number, 30 to 40% of us probably have that defect, which is basically telling us that we don't methylate our B vitamins well. So if we pick a product that just says B and it's not a methylated form of the B, we're actually going to have trouble utilizing that. And that's where those products that are in the methylated form are super important. So you can either test for that, get confirmation, and then utilize methylated versions, or quite frankly, just buy the methylated B vitamins and take care of it on that end as well. So yes, super important. What you'll see on a blood test that also helps you is if you're supplementing and you don't see the Bs increasing as you wish, that could be an issue of how we utilize them. Or if then the B vitamins are so high and we can't downregulate that, that also could be because we're also not metabolizing it well. And now we get increased levels in the serum that are just sitting there not doing us any good. What else, Amy? Where else do you want me to go?
Let's see. It looks like we got an answer about the tinnitus, and they're talking about pre-existing tinnitus and just sort of solving for that.
Oh boy. So, yeah, that's a loaded, fun question. So as strange as this is going to sound, one of the very first places that I look if it's not musculoskeletal is food sensitivities. A lot of times it's very interesting that tinnitus, any sort of ringing in the ears, even sometimes associated vertigo, is an inflammatory reaction to some of the foods that we're eating. So like I would pull out gluten for sure and see if that helps. Dairy, sugar would be my very close second and thirds, and then certainly testing at that point if you can't get an answer for those three. Oh, I like this one. Is there a test for inositol on regular labs? I do it on micronutrient testing. So I would love to tell you I get that through my regular reference lab, and I don't know if that's possible through like a Quest or a LabCorp, but some of my specialty labs. Amy, am I allowed to say who they are or no? Can I answer that?
Yes.
Is that okay? Okay.
Yep.
Since we're past the hour, right? So I use Vibrant America for my micronutrient testing. Awesome reference lab. That's a specialty lab. SpectraCell is another good one. Okay. But Vibrant America would be my go-to. And you can check those levels of inositol, choline, methylmalonic acid. There's some really great metabolites that are checked on that test, which is awesome. Am I allowed to answer what is a good source for the combination of Boswellia?
Yes. Yeah.
Okay.
Go for it.
Actually, the combination that I talked about is called Ake Action, and it's a protocol for life balance, but that gives you the three. That's the Boswellia, the ginger, and the white willow bark. So that's awesome. I don't know off the top of my head one that has all five in there, but that would be a great search on the Fullscript platform in order to see if we can find those five all together. That would be great. What else here? Being the active ingredient in aspirin, are there any known side effects to the GI with the use of white willow bark? A whole lot less, but like anything else, you got to try it, right? If the patient's experiencing some GI symptoms, then you've got to find an alternative or just cut back on the dosage. But generally, I can use that without any problem. What was the micronutrient test name again? Vibrant America is the lab name, the company name. Right. And if you need a contact, I have no financial gain in this, but if you do need a contact, send me a text. I'm happy to connect you with them. Let's see. Do you ever use PEA, SPMs, and non-nutritive options such as X39 patches, FSM, magnetic therapies? Myofascial relief? Yeah, yes, some of those. So the SPMs, especially in that anti-inflammatory world, yes. I'm going to fully admit I do not know, and I'm not familiar with X39 patches. So you're going to have to educate me on that one. Magnetic therapy, certainly sometimes myofascial release. I mean, we do acupuncture, we do cupping, we do the Takar therapy. I have a massage therapist. I mean, we're going to pull in any gun that we have on that side, certainly to utilize. So yeah, great ideas to throw out. Paula, I appreciate that. Send me a text. I want to know what those X39 things are. I got to learn something myself today. Please spell combination of Boswellia ginger. Okay. Ache, A-C-H-E, action. Like I'm moving into action. Ache, action. That is the name of that. Thoughts on cannabis and CBD for pain? Yes. Please don't buy it at a gas station. I mean, I know that sounds ridiculous, right? But patients are buying this stuff at gas stations. So get them on the Fullscript platform and use one of the products there. That one, again, I think it's hit or miss. Like, I think it works beautifully for some patients for pain. Sometimes it's a matter of finding the right dose, right? So sometimes 50 milligrams isn't going to do it. 200 milligrams will do it. And you've just got to play around a little bit. There's a couple great companies out there. Just get a reputable one, as you're playing. Let's see. Could magnesium help with tremors of hands or any? Oh, yes, absolutely. Play with the glycinate form of that first on the magnesium for the tremors. Look at B vitamin status. I also see a ton of B vitamin deficiency when it comes to tremors of the hands. And then find an awesome chiropractic neurologist. I'll tell you a crazy story. My daughter, who is a pilot, actually has hand tremors. And I did all the great, metabolic work that I know how to do. And she was super deficient in B vitamins, and it helped a little bit. And a very awesome colleague of mine in Chicago, who's a chironeurologist, laid his hands on her once in terms of, and I'd love to give you the exact what happened, but I'm not a neurology expert. He laid his hands on her once with whatever he saw through her eyes in terms of how her brain was functioning. And after one simple adjustment, the tremors actually went away. So make sure you're seeking out the neurology side of what we do in the chiropractic world on the functional side to help you with the hand tremors. Life-changing for her. Excellent. Oh my gosh, I did that at like 100 miles an hour, Amy.
We did it though. We answered everybody's questions, so we're all super thankful for sure. Excellent. So I know we definitely went a little bit over time, but thank you for everybody who was able to stick with us here. And thank you so much to everybody who attended today. And also thank you so much to Dr. Cindy Howard for this great presentation. Everyone look out for an email with a link to view this recording, as well as a special offer for Protocol from Life Balance. Anyone who has any additional questions, you think of it later as you're going along on your day, you can send them over to me at amy.regan, R-E-G-A-N @fullscript.com, or give Cindy a text like she said. I hope everyone enjoyed this presentation. And just sort of wrapping us up, Cindy, some final thoughts here.
You know what? And I appreciate that. First, again, just a big giant thank you. And to just, keep studying, keep learning, keep educating, and go out and be brilliant. And just let's keep changing the world. And one patient at a time, we're going to get people better.
That's definitely a motivating statement for a Monday afternoon. So thank you so much, Cindy. And thank you so much to everybody else. Everyone enjoy their day.